So we'll let you know about St. Augustine later, just got here. Okay, so today's presentation is Dan Cooper, and he's going to be talking about understanding PASC in children and adolescents, fatigue, immunobiology, and exercise testing. And it's certainly always important and quite a timely sort of thing right now. And next week, we're going to have outcomes of COVID-19 and people with hemophilia, and the monthly Recover Long COVID project team updates. The 30th is Memorial Day holiday. The 6th will be a highly effective protocol for treating long COVID patients that completely resolve or significantly improve symptom burden. Then on the 13th will be BARDA challenge updates. 20th is another holiday, Juneteenth holiday. The 27th is PPRL validation processes, and the monthly Recovered Long COVID project team updates. And then July 4th is July 4th. So we have quite remarkably 5 million COVID positive longitudinal records with 13.2 million people in enclave. And Dan, without further ado, so if you could share your screen, I'll stop sharing.
Okay, here we go. Okay, well, thank you. I hope everybody can see this. I take that we can. It's really an honor to be here. And I thought I would try to go through rather quickly and have a lot of time for questions. What we have been thinking about in terms of this long COVID or PASC in children. And I want to thank, obviously, my colleagues from the ICTS. And there we go. Yeah, just so you know what I used to be. This is the work of the Pediatric Exercise and Genomics Research Center run by Dr. Shlomit Isaac. And we have collaborated on and are collaborating on a number of really interesting projects that are focused on exercise in children. We'll try to go through this, as I said, quickly and really open it up for questions. Obviously, we're interested in this. This was a recent article that appeared in Nature in February. I love the title, Long COVID in Kids, More Research is Urgently Needed. And what little is known about long COVID in children and teenagers suggests that it can be just as disabling as it is in adults. I'm a pediatric pulmonologist and I'm still active clinically, and I'm seeing this as well. And it's taking many, many forms. But it seems that when we consider pediatric post-acute sequelae, that fatigue, as in adults, is emerging as a cardinal symptom. Here's, it's a tough concept, fatigue, and this is the definition that I found from the University of Rochester Medical Center, which I think is vague enough, but at the same time accurate enough that we can work with it. And that is this: it's a feeling of being tired, weak, or exhausted. Now, of course, one of the other major symptoms, in addition to the fogginess and the neurological symptoms that may be related to fatigue, is the idea of dyspnea, which is difficult or labored breathing and shortness of breath. And again, we're seeing both of these symptoms in children and adolescents. We tried to kind of put this together in a construct where, in order to understand a complex symptomatology like fatigue, we really have to look at it from a number of different aspects. So you've got fatigue and dyspnea, and you have cardiorespiratory and metabolic, and this is predominantly what we'll be talking about today, which is going to give you impaired exercise. And what goes along with that often is disordered sleep. There are behavioral and neurocognitive, which we can get at through surveys and questions. This can lead to depression and poor school performance. There's immune dysregulation, issues of vaccine responsiveness, and disease susceptibility. And the way to measure this, at least one of the things we would like to do is look at both baseline and look at exercise as a stress for the immune system, which we'll talk about in a few moments. And one thing that we have to remember when we look at any pediatric disease is the impact that a particular disease might have across the lifespan. So we know that, for example, many cardiovascular diseases like atherosclerosis in adulthood begin during childhood. And with the promise, the NIH promise and the PHQL, we actually have tools that we can use to delineate the symptomatology of fatigue and use it to quantify its relationship with other cardiorespiratory, sleep, and immune dysregulatory mechanisms. We also have to remember that we cannot look at this problem of long COVID in children absent an understanding of social determinants of health and health disparities. And everybody on the call is well aware of the health disparities that we saw magnified by the COVID pandemic. And as we begin to better understand PASC and long COVID in children, as we look at specific cardiovascular and respiratory mechanisms, at behavioral and neurocognitive, and an immune inflammatory, it's all within the context of social determinants of health, issues of race, ethnicity, socioeconomics, and the environment. This is just some preliminary data from one of our colleagues here in Orange County, Dr. Laura Glynn, who is an outstanding behavioral researcher, showing that there is evidence of increased fatigue, depression, and concentration. And this was groups of uninfected kids and SARS-CoV-2 infected after they'd been infected. And in each of these metrics, fatigue, depression, and concentration difficulty, the kids who had been infected seemed to score higher. So I think there is mounting evidence that certainly things like fatigue are going to be associated with whatever long-term PASC symptoms we see in the future. Well, I thought it would be useful to go a little bit over the past 2 years so that the people listening can understand, why are we studying this? Why is my group interested in? So at the very beginning of the pandemic, we were faced with this issue of the school closures. And as a pediatrician and as someone who's interested in exercise in children and has done many, many school-based studies, I realized that this was no small problem. And the role of the university in working with the community would be critical in trying to figure out what the best pathway for schools were, particularly at the beginning of the pandemic, where in Europe and in Asia, many schools had just closed down. And in the United States, many schools closed down as well. And this was a picture from one of our collaborating schools from Ruben, who is a super scholar at the Madison School in our district in Orange County, in which he says, "Hello to all my Madison School friends. I hope you are all doing well. I miss you all. Hope to see each other soon, and stay safe." So my own background in this really goes back early 2000s, when we were part of one of the most ambitious NIDDK studies ever undertaken, which was to figure out how we could prevent obesity and type 2 diabetes in children in school-based populations. And Project Healthy emerged, which was a large study. And this was one of the articles that came out of it that appeared in 2010. And this was our school-based intervention for diabetes risk reduction. And I point this out because this was, although we had done studies in schools before, this was one on steroids, where across the country, there were 42 middle schools. Almost all of them were Title I schools. We enrolled 4,600 students of a very diverse background. And at the beginning of the 6th grade, and we followed these kids for 3 years, and the end of the 8th grade, the students not only went through measurements of body mass, waist circumference, and nutritional and physical activity metrics, but we actually did fasting glucose and insulin levels. So this was quite an undertaking. And it really taught our group how to work in these schools, and it really attuned us to what was going to happen with the school shutdowns. And so we formed in our region what was called the UCI-CHOC, which is Children's Hospital of Orange County. That's our major children's hospital affiliated with us at UCI. We formed the Healthy School Restart Group. And we had many purposes, and one of which at the very beginning of the pandemic, as you remember, was to help schools develop plans for which they could stay open. And we did take a stand where we thought that we'd like the schools to stay open as much as possible, but to do so in a safe way. At the very beginning of the pandemic, we organized a group of fantastic people. You probably recognize some of these names. And we wrote an opinion piece in JPEDS about reopening schools and how to do it. And then we were able to actually get funding from UCI and from the Orange County Healthcare Agency. And we did a study in the schools themselves in which we enrolled about 350 kids in 4 very different schools. And we looked at, we were able to draw blood in 90% of the kids. We did nasal PCR, and we were trying to get some sense of immune pathogenesis among school-age kids because there was a total lack of data. And if we were going to advocate any methods to keep the schools open, we needed to understand this better. We developed an approach towards the systemic observation of how well the schools were doing. It's called SOCOM, which we were able to publish, and we've got some ongoing studies. We looked at the vaccine issue. More recently, we've done some focus group studies on adolescent COVID vaccine decision-making among parents in Southern California. And we've got a study that's about to come out in JAMA Network about COVID-19 disease severity. So we became immersed in this whole situation, and we realized that the long COVID issue was going to become important. One of the things that we discovered, and it's related to how we view the issue of long COVID, was that infected children actually had a different pattern of immunological responses, particularly with innate immune cells, like monocytes and NK cells. And they had reduced monocytes and NK cells. And this kind of began a theory which has been subsequently validated in other studies, that the kids actually had a pretty good T-cell immune response. But the fact that they had fewer monocytes and NK cells compared to uninfected kids suggests one of the reasons that their symptomatology may have been reduced. And there were healthcare disparities throughout. Probably the most interesting one here is this panel A, where we had 4 schools, A, B, C, and D. These were at 2 separate cycles of the pandemic. This was early, and then this is when we had a surge just before 2021. And you can see in schools A, B, and C, which were predominantly in Hispanic, lower socioeconomic neighborhoods in our region, whereas school D was in a rather affluent neighborhood, the background rate of the infection was much higher. And when you looked at the schools themselves, again, A, B, and C being the schools that were in the lower socioeconomic, predominantly Hispanic areas hit hard by the pandemic, the cases were much higher than in this school. We also found no difference in infection between remote and on-site learning, which suggested to us that just keeping kids home might not solve the problem. And a really interesting finding was that 26% of the learners with low HDL, and this is the cholesterol that is reflective of fitness. So when it's high, you're physically fit, and when it's low, you're probably not. And there was this correlation, and I think everybody on the call knows that the disease symptomatology was much worse in people who were obese and unfit, and this is true for both adults and children. So fatigue has a very complex psychobiology. It goes from the brain to the muscle, and it may be due to alterations from the brain, commands through the nervous system. Why do you feel fatigue? The actual activation of the motor units, the neuromuscular propagation, the excitation contraction coupling, the availability of metabolic substrates, the state of the intracellular medium, performance of the contractile apparatus, and blood flow. So when we deal with something like fatigue, we have to be prepared for to try to understand this very complex physiology. And it's interesting that when you look in the literature and diseases where fatigue has been studied and is a huge problem, such as in cancer, that there is a fairly recent and growing understanding that the immune system is somehow involved. This is from a nice review on the role of fatigue in cancer treatment. And it's interesting that they talk so much about the role of innate immune cells and the cytokines. We don't have time to go into this, but obviously there's an interplay between psychological behavioral processes, the neuromuscular mechanisms that I alluded to, and ultimately the perception of fatigue. And as we think about what's going on with long COVID and trying to look at some systematic observations of exercise testing or physical activity, we've got to remember that the closure itself, and perhaps the very fact that the pandemic almost represented an adverse childhood event, which we called ACEs, was very profound. So here's a study that looked at moderate to vigorous physical activity, which is where your heart rate is at least 140 or above in kids. And this is what they found prior to school closure in several schools, and then after the school closures. And if you look at sedentary time and you look at other indices in other papers, it's pretty clear that the school closures themselves and the whole existence of the pandemic has had an impact on physical activity and, in fact, on weight in children. And any attempt to study these things post-pandemic, and we're certainly not post-pandemic, but any attempt to study these things must take into account the fact that there's probably a global shift in physical fitness and activity in kids. And another factor that we have to consider, and those of us who've been in the field know this, here's a really interesting paper that came out in the New England Journal of Medicine many years ago. And the title is very compelling: The Morbidity of Cardiac Non-Disease in School Children. And what these investigators did was they looked at the effect of kids who had been told that they had innocent murmurs, that is, murmurs that were non-physiologically important, but you can sometimes hear murmurs in kids from normal hearts. And what they found in this paper was that the amount of disability from cardiac non-disease, mainly that these kids were prevented from participating in physical activity in schools and in outside extracurricular activities, that the amount of disability from this cardiac non-disease in children is estimated to be greater than that due to the actual heart disease. And so as we consider what the long-term effects of having had COVID or even lived through the pandemic, we have to remember that there are these factors that we may not otherwise have accounted for. And of course, we know that children are not just miniature adults, and I had to de-identify these pictures, sorry about that, for HIPAA reasons. But we do know that exercise is essential for growth and development. And as we consider PASC in children, the immunological, physiological, and neurocognitive effects that we talked about that are constituents of the fatigue are changing as children grow in development. As children grow and develop, and their perception and their ability to do physical activity and their ability to assess things like fatigue changes as well. So this adds to the complexity of any attempt to try to understand fatigue in the context of PASC in the pediatric age group. It's equally important to remember that this concept of the pediatric origins of adult disease, and this has certainly become a topic of great interest in the past several decades, where we're beginning to understand that health-related issues during childhood can have long-term effects, and they may be mediated by epigenetic or genomic effects or other effects that we're not aware of, but they become quite important. So we know that chronic fatigue syndrome is associated with Epstein-Barr virus, and there was this fairly recent article about Epstein-Barr, EBV virus, and multiple sclerosis that I'm sure many of you read, where they looked at huge amounts of data and were able to find a correlation there. Metabolic syndrome is associated with kids who have acute lymphocytic leukemia. Asthma is related to childhood respiratory syncytial virus. Chronic lung disease, both in children and adults, is related to early life adenoviral infections. And adult respiratory disease and neonatal or pediatric diseases that require prolonged assisted ventilation can contribute to the development of adult respiratory disease. And there are many, many other examples where we've got childhood diseases and that contribute to health across the lifespan. And as we consider pediatric PASC, this is an issue that we should be focusing on as well. Well, there are these three major systems that we think are related to PASC. One is cardiorespiratory, one is behavioral neurocognitive, and the third is immune and inflammatory. And in each of these, we can find a connection to fatigue. So we know that if you study fatigue carefully, there are studies that show that peak VO2, which is a marker of cardiopulmonary exercise testing, which we'll get to in a second, is associated with fatigue. Behavioral neurocognitive fatigue is associated with depression, anxiety, and sleep rhythms. Immune inflammatory, and for example, in children with pediatric inflammatory bowel disease, fatigue is associated with metrics of chronic inflammation. So there is a strong relationship between each of these three, what we consider to be the key symptoms that we would have, the key systems that we have to look at, and fatigue as it may relate to PASC. Now, the good news is that fatigue itself, as complex as a symptom as it is, it can be measured and scaled in pediatrics. And there's a couple of good approaches. One is the NIH PROMIS fatigue, and the other is the Pediatric Quality of Life Multidimensional Fatigue Scale. And here's some examples where in fairly recent literature, these scales have been used to make inferences and understand mechanisms with other symptoms. So for example, you've got fatigue associated with physical activity in childhood cancer. There is a nice review article on self-reported health outcomes that includes the PROMIS fatigue scale in a variety of chronic diseases. And using the PEDS QL, you could detect the effect of a 3-week inpatient body weight reduction program for kids and adolescents. So as you try to figure out ways to study this problem, at least we've got some fairly well-validated ways of assessing fatigue and compare them to things like cardiopulmonary exercise testing. So what can we learn from cardiopulmonary exercise testing in children? And this is a kid on how we do exercise testing. We use a cycle ergometer. This is usually pretty much fun for the kids. They enjoy it. And this is the famous gears from the late Carl Wasserman, who was at Harbor UCLA Medical Center, one of the pioneers of understanding the exercise physiology and its role in disease and in clinical diagnosis. And these are the kinds of things that you can study when you do a relatively non-invasive study of gas exchange and heart rate, going from mitochondria through the muscle, the heart, and the lungs. And all of these factors, fundamental issues of central and peripheral control of breathing and upper airway dynamics, and even gene and hormonal regulation of muscle hypertrophy, you can get useful information from formal cardiopulmonary exercise testing. I just want to show you what a typical max exercise test looks like.
Go, 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 good job. Come on, push, push, push. Good job, buddy. Go, 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 go. Almost there. You move your legs, push, 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 push. Almost there. Go, 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 go. Move your legs. Go, buddy. Go, 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 go.
So I show you that because you can see from a maximal exercise test that part of it is physiological and part of it is also encouragement. And that dichotomy actually might prove to be very, very useful in figuring out fatigue in children. So this is what we get when we do a cardiopulmonary exercise test. So imagine you're measuring oxygen uptake on the y-axis and we're looking at time, or we could be looking at some other variable on the x-axis. And that's the work rate input that we use. We call it a ramp, which means that it's getting harder and harder as you cycle. The experience, for those of you that haven't done a test like this, is it's as if you're riding up a hill and the hill is getting steeper and steeper as you go along. And you ask the participant to keep exercising for as long as they can. And we phrase it as until you reach the limit of the subject's level of tolerance. The data looks something like this. And then this is the classic part of an exercise test that everybody's familiar with, and that's the VO2 max. And what happens, and what has been so remarkable, is that at some point, you see that the work rate can continue to increase, but the individual's ability to increase oxygen uptake reaches a plateau. And about 100 years ago, when this plateau was discovered, it was really amazing to the physiologists at the time because they said, here is a true physiological limitation. And that's one of the reasons that VO2 max has become the iconic gold standard of physical activity. And we don't have time to talk about it now, but there are other ways of looking at an exercise test. There's all this rich data that's in the submaximal portion, and we'll show you how we can use some of that as well. For example, just look at the relationship between oxygen uptake and heart rate in a submaximal portion, and we can learn tremendous amount about fundamental physiology. This is what actual data look like. This is cycle ergometer in a 10-year-old girl. We have oxygen uptake. Here we have the work rate. There's this interesting linear relationship until you reach the point where the child or the participant says, I can't go on. Just to give you an example of the interesting diagnostic capability, here is again the relationship between oxygen uptake and in this case heart rate. The work rate is getting harder and harder, so oxygen uptake is going up. And we compare a healthy child with a comparable aged child who has congenital heart disease. And you can see distinct differences in these patterns where even though heart rate is going up to the same extent, the ability of the child to increase oxygen uptake is substantially reduced, probably because his stroke volume is reduced. And this is one of the ways in which formal laboratory cardiopulmonary exercise testing can be so useful in trying to understand fatigue. I just throw this in because we think sleep is very important. This is a preliminary data that was published by our colleague, Dr. Nakrug, in which they looked at the slow oscillation during sleep, and they compared it in these kids to what their peak VO2 had been on an exercise test. And they found that cardiorespiratory fitness was associated with greater prefrontal slow wave activity in NRM sleep, indicating more mature brain development. So all of these key physiological epochs in life, sleep, exercise, are interrelated. And I think we're going to have to address them all simultaneously if we're going to figure out the fatigue that can exist in some kids that have been infected with SARS-CoV-2. We have an ongoing project from the NIH called Project REACH, which stands for Revamping Exercise Assessment in Child Health. And this study was originally focused on sickle cell disease and cystic fibrosis. It was interrupted a little bit, though we've managed to do some great work, by the pandemic. And we recently got approval from the NIH to add to our cohort kids who had been infected with PASC. And we've enrolled about 15 children so far. We've just started enrolling kids who have a history of PASC and fatigue. Here's an example of CPET, cardiopulmonary exercise testing. This is in a 14-year-old girl who complained about fatigue. She'd been very athletic and she was in water polo, and now she complained months later that it was difficult for her to do her water polo routines and training. And here we see from our lab, again, the oxygen uptake is a function of heart rate in this child, which was about 78% predicted. So whether we're able to continue to detect this level of abnormality remains to be seen, but there's a lot of interest in the idea that there may be a vascular or cardiovascular mechanism for the fatigue associated with SARS-CoV-2 in adults. We may find this in young adults and in children as well. It's really important to make this connection also between exercise and the immune system. And these are studies that we've done over the years because it's an area we're very interested in. When you exercise, you stimulate your immune system, you get a leukocytosis, and you actually change gene expression. And here's a summary of studies that we've done over the past 12 years, where we look at the immediate effect on gene expression in circulating white blood cells, comparing early pubertal and late pubertal. They're not exactly the same. There's an overlap of some genes, but what's interesting is that the genes pathways that are predominantly affected are genes involved in infectious disease responses. And so the connection between fatigue, exercise, and diseases like SARS-CoV-2, we may get some insight by looking at the acute response to exercise and focusing on these kinds of studies. This is a recent study that looked at acute exercise this was a single individual who had been infected. He was part of another study, an adult. And the results of this study were fascinating. They found that a single exercise bout mobilized large numbers of SARS-CoV-2 specific T cells with broad T cell receptor diversity against COVID antigens and an enhanced ability to respond to recall antigens. And they concluded that of particular importance is the potential that an exercise boost in the anti-SARS-CoV-2 immunity could reduce the viral reservoir and maybe improve symptomatology in those with long COVID syndrome. This obviously is very speculative and remains to be seen. And again, this connection to innate immunity we think is very important. So again, the pediatric origin of atherosclerosis. We know that the monocyte, for example, plays a big role in the adult atherosclerosis. It begins during childhood. We know that exercise can affect how monocytes function. We think that exercise and physical fitness leads to the kind of monocytes that patrol and repair rather than the kind of monocytes that contribute to vascular damage, inflammation, and ultimately to the development of plaques. And we know that diseases in childhood, like severe influenza, can be associated later in life with atherosclerosis. So this is, again, a number of reasons that we want to study these various mechanisms simultaneously in these kids. And there's an emerging idea about the immune system, which is the old friends hypothesis. So this is put forward by a really well-known microbiologist in England who's been studying this for many years. They used to call this the hygiene hypothesis. The people in the field don't like that name because it implied that you should eat dirt and stay and don't wash your hands, which is not a good message. Really, rather the idea is that when the immune system develops at birth, the hardware is in place, but it's awaiting real world data to shape its ongoing development. And some of the elements of real world data could be exposure to helminths, to fleas, to microbiota. And we'd like to add levels of physical activity can also shape the immune system across the long term. And then, of course, there's the effect of pandemics, of agriculture, of social determinants of health, of war, of climate change, and the built environment. And each of these can be affected differently by these factors. And this is the way that the immune system is modulated, and it has to do with resilience and maybe to identifying which individuals develop long-term consequences to viral diseases like SARS-CoV-2. An interesting article has recently come out in the Journal of Applied Physiology. They put together a kind of a nice idea of from heart to muscle. What are the pathophysiological mechanisms that underlie long-term sequelae to SARS-CoV-2? They've tried to identify what evidence is strong, what's moderate, and what's unknown. And they looked at the various symptoms. They're focusing a lot on the potential of cardiac damage and on vascular function. These are things that you can begin to assess with an exercise test. And whether these other areas come through remains to be seen. And the role, of course, of the immune modulation of each of these is very strong. They did a review of the studies that had been done to date. This paper came out just a couple months ago. And they looked at a number of studies where adults had been undergone cardiopulmonary exercise testing. And they looked at VO2 peak. And again, comparing control to COVID, you find in 3 major studies that there is a general reduction in fitness in people that had had COVID, and this may become a biomarker for long COVID. And one of the things that this group also did was they wondered, could this have been just the result of bed rest per se? And so they speculated, looking at studies that had been done in bed rest, how much of a decrement in VO2 peak could we expect from bed rest alone? And that's these black lines at discharge for patients that had been hospitalized and 6 months later. And you can see that there is a big gap between what has been found in the data and what could be expected just from the unfitness and the deconditioning that occurs from bed rest. Well, we're in a new era now, and we measure physical activity in many new ways. This is physical activity in a 10-year-old girl using a wearable monitor. This is Wednesday, Thursday, Friday, and Saturday from 12 a.m. You can see, obviously, there's a great deal of activity starting in the morning, more so on Friday and Saturday than on Wednesday and Thursday. But there are ways of quantifying physical activity. And unlike what we measure typically in the lab, this is naturally occurring patterns of physical activity, which is not sitting on an ergometer for 15 minutes and pedaling up a hill, but rather stop, start activity. So it's a very different kind of activity, and you can get a long-term activity. And I was fascinated by an article which literally just came out that estimated the burden of influenza-like illness on daily activity at the population scale. And this is using commercial wearable sensors. And their question was, how can the true burden of influenza-like illnesses be estimated, given that most cases are mild and go undocumented? And they looked at 15,000 adults who had been wearing these wearable sensors, and they discovered an overall reduction in mobility equivalent to 15% of the active US population becoming completely immobilized for one day. And more than 60% of this reduction occurred among persons who had sought no medical care. And so this study suggested that the burden of ILIs is much greater than previously understood. And as we think about pediatric PASC, it may well be that if we use novel assessments of activity, we may find a very different picture than we would just from in-laboratory exercise testing. Well, we've reached out to our community. This is a community engagement studio where we talk to kids who'd had PASC. In the words of one 9-year-old, I want to know if I'll be healthy, if I can go back to school, and if I can play sports with my friends. We were trying to gauge whether or not kids would volunteer for a study. This is one of our fantastic school principals who is a true heroine, and in the pandemic was when schools were shut down and most of the kids in her schools relied on school lunches and breakfasts. She was literally delivering food to parents' homes at a time when the levels of the viral infection in that community were really high. And she became a big advocate and a great partner. And they talked to the local school district that if we want to be part of CHOC UCI studies, she's all in favor of it, because this has become so important to them to see what the long-term consequences are. So we're focusing on cardiorespiratory right now with our REACH project. We are looking for ways to expand this so that we can simultaneously look at biobehavioral with polysomnography and immunobiologic studies. And with that, I would love to hear from any of you questions that you may have.
Great, that's fantastic talk, really fascinating.
Thank you.
Are there questions? So I'll start out. I have a few. This was absolutely fascinating, and so the oxygen uptake test seems very simple and very revealing, and so it would seem to me that this could be distributed as a point of care test and done remotely. Have you been doing that or thinking about doing that? Because that could really, I mean, the thing that's exciting about this is that having been involved in PASC research for adults, the effort to actually quantify this it's really tough. And it looks like you really, at least in the pediatric population, have nailed down a number of ways of quantifying this, at least certain aspects. And that seems to be one of the simpler ones. So maybe talk to us about sort of remote sensing options involving.
Right. So there, from a remote sensing point of view, a formal cardiopulmonary exercise test where you measure oxygen uptake, at least with the technology that we have, needs to be done in a lab. It's non-invasive, but you have to come to the lab to do it. And you're right, it can be very, very revealing because, again, all you're measuring is stuff at the mouth. It's minimally invasive, and we do millions of them every year. And it does give you this really detailed understanding of the physiological mechanisms like cardiac and vascular, and you can differentiate between lung disease and heart disease. So at the beginning now, where we still don't know, I do think there's a role for formal laboratory cardiopulmonary exercise testing. It does a couple of things, Joel. It's interesting because one, it can reveal underlying pathophysiology, which is important. And let me speak as a pediatrician now. The other thing that is useful about this, and I alluded to this cardiac non-disease question, is we've studied a lot of kids with lung disease or cardiac disease, and this may be true with PASC because I'm getting a feeling that a lot of parents are very protective of their kids, as they should be, and they're worried about letting their kids go out and exercise having had PASC, for example. If you bring them to the lab and you do a maximal exercise test and you show the parent and the kid that they had no problem doing it, that's actually very, very useful. So that's the other side of it. Now, there are non-invasive and there are remote approaches like the wearables, right? And that study that just came out, the one on the flu, just came out in JAMA Network, that was all remote data. And, this is down, people had their various watches and they downloaded the data to a central site. And we certainly can do that with kids. Now, wearable devices in kids are not perfect, but I think as shown by that study on people who had influenza, that's also a possibility. The third response, Joel, is that there are tests of physical activity that are not so lab dependent. So for example, we do school-based physical fitness testing. It's mandated in 12 states in the United States. In other words, by law, the school has to test kids' physical activity in the 5th, 7th, and 9th grade, I should say fitness. And they do it either with what they call the mile run. Any parents on the line here know that the kids hate these tests usually, but they do a mile run or they do what's called the shuttle run. And those data in those 12 states represent about 60% of the kids in the United States. And those data are being collected as we speak. And what I think a very wise investment would be from a public health perspective would be to make sure that the quality of that data is good, that there is interoperability among the schools in the way that it's done. And then we can begin to look globally as to whether or not there has been a global effect. And if we could get around the HIPAA and the FERPA rules, maybe even discover if there's an affected kids who have been infected with SARS-CoV. But I think, pretty soon almost every kid will have been infected with SARS-CoV-2.
Right. So to what degree do you see, you presented a lot of data, but what is your gestalt as to what degree PASC is different from other post-viral syndromes? Obviously you don't really know, but
I don't know. It's a great question. It's the question we all want to answer. It may be, as we look in retrospect, that we wish we had studied those like flu a little bit, better in terms of cardiorespiratory fitness. I don't know. The studies in the adults, some of which were done in young adults, some of which were done in relatively symptom-free infected adults, suggest that there may be long-term effects, and that these long-term effects may have to do with either cardiac or vascular abnormalities, meaning gas transfer, probably, that we can measure. I don't know how different it's going to be.
Great. So David Sarner has a question. Thanks for this very interesting talk. Any feelings on the causal relationship between immune dysregulation, fatigue, depression in kids? In other words, which is the chicken and which is the egg? I imagine the chicken egg roles might be switched in certain contexts. Is there a positive feedback cycle?
I would argue that it's a sort of a double hit. I would say that there is a combination of being physically unfit, which is why we saw that kids and adults who were obese and or who were physically unfit, you didn't necessarily have to be obese, were more likely to have more severe symptoms. We do know also, for example, that people who are more fit tend to have better responses to influenza vaccine for whatever reasons, because you stimulate the immune system in a positive way. So I do think that there is going to be a double hit of both physical inactivity and immune dysregulation that may have occurred as a result of the initial SARS-CoV-2 infection. The literature that I've seen suggests that there may be some long-term immune dysregulation, particularly in some of the innate immune cells, like the monocytes, that result from an initial SARS-CoV-2 infection. And that, in combination with the lack of fitness, might contribute to this disorder. The good news there is it may well be, and there's one article that I found in adults, where looking at rehab and exercise programs, you were able to overcome some of the physical fitness deterioration that one had seen. Whether this now deals with the immune problem as well, maybe.
Interesting. So after somebody actually has been infected and they have PASC, then exercise might be actually useful.
Exactly, and I think we need to figure that out. I think we need to find out, you know, again, what is emerging as a novel idea is that exercise plays a role in conditioning the immune system. So if there is a primary immune hit from SARS-CoV-2, which contributes to some of the symptoms of PASC, it would be nice to know if exercise could ameliorate that. Now, the problem there is that when you say exercise, it's such a big word. I mean, what does that mean? Is that 10 minutes in the morning, every Wednesday? Or is it every day? Or is it 30 minutes a day? And those are some of the questions that we have to get at.
Oh, right. And what sort of exercise?
And what sort of exercise?
Jogging. Yeah. So do you have any sense? I mean, I would, yeah, I have no idea. I mean, you know, has there been work on relative immune impact of different types of exercise?
Oh,
or
yeah.
Is it...
Yeah, most of the work has been done predominantly on aerobic, what we call endurance type exercise, like running, jogging, those kinds of activities, as opposed to strength training. But there is a growing body of work that also shows that strength training can have salutative effects on the immune system as well. And, you know, and remember that exercise is one of these things that an otherwise healthy person can do in daily life activities that profoundly perturbs cellular homeostasis. So when you go out on a jog, you increase the number of monocytes in the circulation. You may double them. You may increase the number of natural killer cells, you know, by 5-fold or 10-fold. You may have an outflowing of interleukin-6. All this stuff happens because of exercise. You know, your pH, if you really push yourself, can go from a normal pH of 7.4, you can get to a pH of 7.1. Now, if you had a patient that came into the ICU or the emergency room with a pH of 7.1, you would be worried. My point is that exercise is a way of profoundly perturbing the system. And so finding the right exercise that stimulates the way you want is really the threading the needle part of this whole thing.
Yeah, no, that's very interesting. When I was at Emory, I was at Emory for a few years. There was a center dedicated to essentially taking, to sort of at a high level, lots of measurements on well patients, and it was an interesting concept. And I'm not sure how much of this they really were able to get into, but you know, obviously dissecting the stuff apart would seem to require very different types of research methods than most medical research.
Can I answer this question from Karen Drucker? She says, do you have any insights into how accurate the VO2 max is as estimated by wearable fitness trackers, and do these trackers exist for kids? So that's a great question. I'm not going to get into too much inside baseball, but and I want to let everybody know, I am in a minority in the world of exercise science. I think VO2 max is a really interesting and important way of looking at exercise, but I think it has, at this point, obfuscated our ability to really understand it. So Karen, for example, if I put a wearable device on a child and I collect, a number of steps and I have a normative data set, in order for me to turn that, so that's a number of steps. So I have to take number of steps. I have to multiply it by all kinds of numbers to turn it into VO2 max, which is liters per minute. In other words, I have to go from steps to liters per minute. So you can see there's just mathematically, there's a lot of stuff that I have to do. And that's because we're fixated on VO2 max. Why not take the data from the wearable devices as the data that we want? It's what we actually measure. And that's my normative data. But we're so fixated on trying to convert it to VO2 max that we forget that the value may be right there. The other thing about VO2 max is I don't know how many people on the call have done a VO2 max test, but if you have, you know that this is really not something that we often do in the real world. We rarely, as human beings, or even mammals, we rarely push ourselves to the point where we say we can't continue. What human beings and other mammals have been evolved to do is to quickly go from one level of activity to another, maintaining cerebral blood flow, so that in the case of humans, when that saber-toothed tiger is chasing you down what is now Hollywood Boulevard, and you're running as fast as you can, you don't faint because your brain blood flow is decreased, and you still have enough cognitive wherewithal to say, should I go to the left and climb that tree, or should I go duck into this cave? So my problem with VO2 max is that it is a non-physiological, extremely effort-dependent test. And that's why I showed you that little clip where you see what happens in the lab, where as the kid, in this case, approached the end of the test, we really had to encourage him. Now, that may become useful in trying to delineate cognitive reasons for fatigue, the perception of fatigue, from the physiological. In other words, the heart's not working as well. So there are a number of studies that have shown, for example, that you can take people who have fatigue, you do a VO2 max test, all the data are normal until that last couple of minutes. And so the heart's fine, the lungs are fine, the muscles are fine. It's just in that part of the exercise where it becomes really uncomfortable that those people don't want to go on. And that's the problem with VO2 max. But we get a lot of information from this. There's a question from Harold Lehman. Do I have 2 minutes?
Yeah, absolutely. Go ahead.
Yeah, you hinted at this in the Star Wars slide, but there seems to be many definitions of long COVID. How do the ensemble of results take this variability into account? So that's a great question. This, I don't have to tell this group that what we mean by long COVID is an evolving topic. And, there's got to be interoperability. The NIH Recover project, of course, is critical in trying, N3C and trying to have terminology harmonization and interoperability. But as tough as that is, and as unsettled as it still is in pediatrics, I can tell you that as a pediatric pulmonologist, one of the diseases that we deal with is asthma. And people who've dealt with that know that actually there is no biomarker for asthma. And its definition is very variable. And the way we diagnose it is fairly fuzzy. It depends on hit or miss physiological tests like pulmonary function tests, et cetera. And yet we've been able to really make strides in controlling it. So I know that this is tough for us to hold in our brains, but we've got, at this point, somewhat ambiguous definitions. Fatigue, the ability to measure fatigue with PROMIS and with PEDS QL. I think we're going in the right direction, but your point, Harold, is absolutely good. And we have to pay attention to figuring out how we can share terms in a meaningful way.
Fantastic. Well, Dan, an absolutely fascinating talk, and thank you, and thank you for everybody who posed interesting questions, and look forward to hearing more about this in the future.
Great. Thanks for having me. I appreciate it.
Okay. Have a great week. Bye bye.